Assalamu alaikum. So today we will be discussing about insulin resistance disorders with special emphasis on PCOS. So insulin resistance is defined as the subnormal glucose response to endogenous or exogenous insulin. It most commonly occurs with obesity, but may result from multiple other underlying causes. The major causes of insulin resistance are divided into inherited causes, that is due to the insulin receptor mutations or certain lipodystrophies, and also secondary insulin resistance. And the most common cause of that is obesity. This is due to free fatty acid and adipocytokines, which contribute to the development of secondary insulin resistance. Secondary insulin resistance is also due to stress or infection, that is due to the excess counter-regulatory hormones, the cortisol, catecholamines, and glucagon. Some medications like steroid can also result in insulin resistance. Then there are certain other causes as well, like inactivity, pregnancy, or immune. The clinical features are impaired glucose tolerance, impaired fasting glucose, type 2 diabetes, coronary artery disease, metabolic syndrome, polycystic ovarian syndrome, and non-alcoholic fatty liver disease. In the clinical manifestation, the most important is glucose homeostasis, which may be variable. The patient may present with overt diabetes or impaired glucose tolerance, or the sugars may be normal and even may have hypoglycemia. It's very common to have postprandial hypoglycemia in someone who is obese, insulin resistant, and this may be taken as the initial sign that this patient in future may develop diabetes or prediabetes. Then there are some cutaneous manifestations, acanthosis nigricans, which is the most important sign of insulin resistance on clinical examination, and may also have skin tags. And then the reproductive manifestations are of the polycystic ovarian syndrome, the oligoamenorrhea, the hirsutism, in some cases, virilization or infertility. Then some other clinical manifestations that are of the adipose tissue, there may be lipohypertrophy, lipoatrophy, and in the lipid metabolism, there may be hypertriglyceridemia. So what happens is obesity leads to increased fat in the adipocytes, and this leads to peripheral insulin resistance. There is increase in the free fatty acid release from the adipocytes. This is from the triglyceride, and the main enzyme responsible for it is lipoprotein lipase. This lipolysis is unchecked when there is insulin resistance, and these free fatty acid will then go to the muscles and liver, and in the liver, they cause the fatty liver disease, which results in hepatic insulin resistance. We know that in the liver, there's hepatic gluconeogenesis, and whenever there is a hepatic insulin resistance, there will be lack of suppression of the hepatic gluconeogenesis. So there will in turn be more and more glucose production or gluconeogenesis by the liver. This gluconeogenesis will cause more and more insulin release from the pancreas, so in turn resulting in hyperinsulinemia and increased load on the beta cells, and at the end will lead to beta cell exhaustion. This beta cell exhaustion and insulin resistance causes type 2 diabetes. So the diagnosis of insulin resistance is basically based on the clinical findings that are the metabolic syndrome traits, the hypertriglyceridemia, hyperglycemia, abdominal obesity, and hypertension. There is currently no validated test to measure insulin resistance in a clinical setting. As a result, we do not routinely measure insulin resistance by the lab. So what are the criteria for metabolic syndrome? So according to the NCEP, ATP3, that is the Adult Treatment Panel 3, metabolic syndrome is present if 3 or more of the 5 criteria are met. Number 1, waist circumference of more than 40 inches or 101 centimeter in men, or 35 inches or 88 centimeter in women. Blood pressure of more than 130 by 85, a fasting triglyceride of more than 150, and HDL of less than 40 in men or less than 50 in women, and also fasting glucose of over 100. So here you can see hypertension, prediabetes, triglyceridemia, and waist circumference, which is the abdominal obesity. All these will result in the metabolic syndrome. So we start with this case. A 21-year-old female presents complaining of amenorrhea for 6 months. She had menarche at the age of 12, irregular and unpredictable menses occurring over 60 to 90 days. So there is oligoamenorrhea. She had bothersome facial hair growth, hirsutism, acne, and weight gain over the last several years. Past medical history is negative. She takes no medications. On physical examination, her BMI is 29, and there is moderate facial acne and hirsutism. Mild acanthosis, no alopecia. Is this a case of PCOS? What is your differential diagnosis? What test would you order? So differential diagnosis of female hyperandrogenism. Remember that PCOS is a diagnosis of exclusion. You have to rule out certain other causes of hyperandrogenism before jumping on to the diagnosis of PCOS. And one of the most important differential is non-classic congenital adrenal hyperplasia, because the patient may have similar symptoms of oligomenorrhea and hirsutism. So you should rule that out, especially in someone who is non-obese and with a family history strongly suggestive of infertility and hirsutism. And how we do that is by the elevated basal 17-hydroxyprogesterone level. Then there are certain other causes of hyperandrogenism, like, for example, androgen secreting adrenal or ovarian tumors. But in them, there will be rapid virilization and extreme hirsutism, male pattern alopecia, and electromegaly. There will be very high androgen level. The testosterone may be more than 200 near the male range of testosterone. And the DHEAS is also very high. Then also Cushing syndrome, but we know in the Cushing's there will be other features as well, like stria, easy bruising, hypertension. Iatrogenic or medication-induced, the patient may be on androgens or DHEA. So these are all the differential diagnosis of PCOS. And one important differential is idiopathic hirsutism. The patient may have a normal cycle, normal menstrual cycle, may have just hirsutism, and on the ultrasound, there may be no polycystic ovarian morphology. Okay, so remember few other contributing or coexisting conditions should be ruled out, like, for example, hyperprolactinemia and thyroid dysfunction, because they will result in oligomenorrhea, and the hirsutism may be due to idiopathic hirsutism. So this will make a lot of confusion. Therefore, in every patient of PCOS, you should rule out thyroid dysfunction and hyperprolactinemia before making a diagnosis. So how to evaluate a patient, a female, for androgen excess? So clinical hyperandrogenism is basically hirsutism. So hirsutism is actually the excessive terminal hair growth, the long, thick, and pigmented hair growth in a male pattern in the androgen-dependent areas, the upper lip, chin, mid-sternum, upper abdomen, back, and buttocks. So it affects around 10% of the reproductive age group, and PCOS and idiopathic hirsutism are the most common causes. You have to distinguish it from other causes like hypertrichosis, which is basically excessive androgen-independent hair. So commonly that may be due to some systemic disorder or medications. So the clinical tool that we use is basically the Ferriman-Galvez scoring system. In this, there are 9 areas: the upper lips, chin, mid-sternum, abdomen, back, buttocks, arms. We have to calculate each area. We have to sum them up from 0 to 4. 0 means no hair, and 4 means frankly virile. And then add them up. If it is more than 7 or 8, that is basically hirsutism. And we know that that's mild hirsutism. If it is more than 14 or 15, that is moderate hirsutism. If it is more than 21, it is severe hirsutism. But some caveats, like, for example, the patient may have done some electrolysis or may have done some laser therapy. So in them, you cannot comment on it. Then a quick word on virilization. In this, there will be concurrent presentation of hirsutism with other signs suggestive of excessive androgen production, like male pattern, balding, deepening of the voice, increased muscle mass, clitoromegaly, and so on. So sometimes we are confused that whether the patient has a real hirsutism or not. In them, we can do the biochemical hyperandrogenism, and testosterone is the most important test to be done in a PCOS patient. So Total testosterone can be done or free testosterone when we have confusion whether the SHBG is causing some problems in the total one. So total testosterone ideally should be done by mass spectrometry, which is expensive, and this is the gold standard method. The free testosterone, although the gold standard is equilibrium dialysis, but it's not available. So what we can do is we can do the total testosterone and then also measure the SHBG and incorporate that into the mass action equation formula, and that will be equally as good as the free testosterone done by the equilibrium dialysis. But remember, the tracer analog method for free testosterone is not recommended. So the basic hormonal evaluation for androgen excess will be the testosterone total and or free testosterone, 17-hydroxyprogesterone, ideally done in the early follicular phase to rule out congenital adrenal hyperplasia. We may be doing DHEAS and also the HPG excess, the LH, FSH, estradiol, plus minus imaging to identify PCO or adrenal ovarian tumor. So polycystic ovarian syndrome is the most common endocrinopathy in reproductive age. The prevalence is 12%, but recent estimates as high as 18%. So the syndrome is characterized by menstrual dysfunction, hyperandrogenism, polycystic ovaries on the ultrasound, infertility, obesity, insulin resistance, and diabetes. So oligomenorrhea is the most common presentation. Classic onset is peripubertal. Hyperandrogenic symptoms gradually increase over time. 75% of women with PCOS are overweight or obese. The rest of them are called the lean PCOS. And 70% have some degree of insulin resistance. One important point is the prolactin may be mildly raised in 10 to 25% of the women. Now, what is the pathophysiology of PCOS? It's actually multifactorial and it's not completely understood. But just remember one thing, hypothalamus produces GnRH that acts on the pituitary and produces the LH and FSH. LH acts on the theca cells of the ovary to produce androgens from cholesterol, while FSH acts on granulosa cells to convert these androgens into estrogen. And FSH also results in follicular maturation for the ovulation. So the most important, the main source of excess androgen excess is ovary. So in the ovary, what happens is actually there is some intrinsic abnormality in the GnRH pulse generation, and it promotes more and more LH secretion as compared to FSH. These LH will cause theca cell, will result in the production of androgens from the theca cells. And these androgens, the testosterone, will result in arrest of follicular maturation and resulting in anovulation. This is more and more supported by the low FSH, which again will decrease the follicular maturation and anovulation. So this was the pathophysiology related to GnRH, LH. But insulin also plays a role, and it's very important. Insulin synergistically acts with the LH on the theca cells, but it also results in the decreased production of SHBG from the liver. So therefore, there will be more and more free testosterone. So the pathophysiology of insulin of PCOS, role of insulin. So insulin is very important. There are some molecular defects identified in insulin signaling that leads to insulin resistance and impaired insulin secretion. It is further exacerbated by obesity. Insulin acts synergistically with LH to enhance androgen production from ovarian theca cells. Insulin inhibits hepatic synthesis of SHBG, so there will be more free testosterone. A quick word about gonadotropins. LH to FSH ratio is usually more than 2 to 3 times. But this may be, this is related to the timing or relative to menses, the OCP use and BMI. And it is blunted by obesity. So the absence of increased LH FSH does not exclude the PCOS, and it is not in the criteria. So what is the diagnostic criteria of PCOS? We follow the Endocrine Society, follow the Rotterdam criteria. Any 2 of the 3 should be positive. Number 1, oligo and ovulation or anovulation. This is criteria number 1. So the patient will have symptoms of oligomenorrhea. And then clinical and or biochemical hyperandrogenism. So if the patient has clinical signs of hirsutism, you don't need to order the testosterone test. And the last one is polycystic ovaries. This is not the first one. This is the last one. If the patient has the first two present, you don't even need to order the polycystic ovaries. But remember one thing, you have to rule out other causes to call it a PCOS. So what is the ultrasound definition of polycystic ovaries? The classic is the string of pearl appearance in which the follicles are peripherally distributed in the ovaries. At least one of the following, more than 12 follicles of 2 to 9 millimeter in diameter. And increased ovarian volume can be used as a surrogate for that. A single PCO is sufficient. But the most important point is that this is not intrinsically pathologic. You cannot say just on the basis of polycystic ovarian morphology, if the patient has no menstrual issues and no hyperandrogenism, this patient does not have polycystic ovarian syndrome. The patient may also have signs like acanthosis nigricans, which I told you is the most important sign of insulin resistance. So cardiometabolic disturbances are actually dependent on the hyperandrogenism. The more the hyperandrogenism, the more there will be insulin resistance, diabetes, NASH, and dyslipidemia, cardiovascular disease. So the metabolic issues, most women, 70% have insulin resistance, independent of obesity when compared with the normal women. There is high risk of type 2 diabetes and non-alcoholic fatty liver disease. The risk of metabolic syndrome is double. There's dyslipidemia, which means low HDL, high triglyceride, and high LDL. There will be more chances of obstructive sleep apnea. So a simple algorithm to the diagnosis is whenever a patient comes, the step one will be if the patient has irregular cycles, that is oligomenorrhea and clinical hyperandrogenism, you have made the diagnosis. You just need to exclude the other causes. The other causes include thyroid and prolactin. Just do the TSH, prolactin, and FSH, and you have made the diagnosis. And certain other causes should also be ruled out. That depends on the clinical setting. The Cushing's, adrenal tumors, and CH, these should be ruled out. And with these two symptoms, you can make a diagnosis of PCOS. If there is no clinical hyperandrogenism or some questionable hyperandrogenism, in that case, you should go for the biochemical hyperandrogenism and exclude the other causes, you make a diagnosis. But unfortunately, if there is either hyperandrogenism or only irregular cycle, in that case, ultrasound is needed. If the ultrasound has polycystic morphology, then this is a case of polycystic ovarian syndrome. So based on the Rotterdam criteria, the PCOS phenotypes are as below, A, B, C, D. The A and B are the classic types in which hyperandrogenism and ovarian and oligoanovulation are present. There may or may not be polycystic ovarian morphology. They both are called classic PCOS and they have high risk of metabolic issues. The C phenotype is hyperandrogenism and polycystic ovarian morphology, but there are normal cycles. So this is called the ovulatory PCOS. They have intermediate metabolic risk. D phenotype is someone who has no hyperandrogenism. They have just the oligoamenorrhea or ovarian anovulation, and they have polycystic morphology. This is the non-hyperandrogenic PCOS. They have very low metabolic risk. So this is just a graph showing the PCOS phenotype. The more and more we have hyperandrogenism, the more will be the metabolic risk. So what are the guidelines for metabolic screening? The Endocrine Society guideline tells us that the first important test to do is oral glucose tolerance test. This is regardless of the BMI to screen for impaired glucose tolerance or type 2 diabetes at initial visit and then at 2 years. If the patient is unable or unwilling to complete the OGTT, then you can do the HbA1c. So this is number one. And then you have to screen for hypertension and dyslipidemia, obesity by BMI and waist circumference. It is also associated with non-alcoholic fatty liver disease, but at this point of time, routine screening is not recommended. So now the treatment. In the treatment, you have to understand there should be patient-centric, and the first question should be whether the patient has desire for fertility or not. If there is no desire for fertility, the patient is unmarried, what to do for them? There are two issues. One is the irregular menses and the other is hyperandrogenism or hirsutism. So what to do for the regulation of the menses? You have to regulate the menses and protect against unopposed estrogen. So for these patients, OCPs will be the drug of choice. But those OCPs will contain the less androgenic progestin. You can also just give cyclical or continuous progestin pills. Metformin will be the second line agent. What are the actions of oral contraceptives on the androgen secretion? The first action is that both ethinyl estradiol and progestin will result in decreased LH production, will suppress the HPG, and this will result in decreased secretion of androgens. The second is the estradiol will increase SHPG, and there will be increased binding of the testosterone. There will be low free testosterone. And then the progestin, especially the third generation progestins, the drospirenone and cyproterone acetate, have antagonism at the androgen receptor level, and they decrease the local action by that way. They also inhibit the 5-alpha reductase, by which way the testosterone is not converted into dihydrotestosterone. So remember this important slide, that androgenic activity of OCPs, the high androgenic activities of the levonorgestrel and MPA. Unfortunately, we have a lot of people prescribing Femila, which contains levonorgestrel and MPA. So they should, Femila should be avoided. All OCPs cannot be used. OCPs with less androgenic potential should be used in someone with PCOS. What are those? They are either the drospirenone or the diene-35. The drospirenone is the Yaz, and diene-35 is the cyproterone acetate. Now, first was to regulate the menses. Second is for the hirsutism, acne, and alopecia. Again, OCP is the first line. And those OCPs which contain the anti-androgenic progestin, like drospirenone, Yaz, or the cyproterone acetate, which is the diene-35. But you should remember that this giving OCP will reduce the frequency by which the androgenic symptoms are occurring. They cannot reduce the already facial hair. For that, you need a local method, the laser or electrolysis or enflornithine. Then second line will be oral anti-androgens. Remember, they are teratogenic. So spironolactone is the most commonly prescribed. We recommend that first 3 to 6 months, the patient should be on OCPs. If still no improvement, then we add spironolactone. But someone who comes with very severe hirsutism, we can start both of them together. And it takes time. So we know the absolute contraindication to OCPs as well. Now let's switch gears and also discuss the other treatment modalities. Remember, diet and lifestyle modification, weight loss is the cornerstone for PCOS treatment. Insulin sensitizers like metformin reduces weight and decreases androgen levels by improving insulin resistance. So they should also be used. TZDs are not recommended. This is a study comparing the lifestyle modification with the drugs. Lifestyle has superiority. When the fertility is desired, obviously lifestyle, weight loss, metformin, and then ovulation induction, either by clomiphene or by letrozole. So I don't want to go into the detail, but this is just the two trials done, PCOS1 and PCOS2 trial, which compared clomiphene and letrozole. The letrozole was superior to clomiphene. That is just a summary of multi-step approach to treatment of anovulatory infertility associated with PCOS. First line is weight loss, and then is the letrozole. Then after that, we can give FSH, and the last resort would be IVF. Metformin improves ovulation and insulin resistance, may be sufficient alone in some patient. And there will be low multiple pregnancy rates and prevents the OHSS with clomiphene. And we know that IVF we have already discussed. But remember one thing, that in pregnancy, metformin should not be continued after the first trimester. Thank you so much.